Good afternoon, Angus. How are you?
Good. How are you?
Good, thanks. I'm just riding my bicycle home about 3, 4 minutes from the Starbucks. So I'm going to turn on my video as soon as I get home.
No worries. Even video is not required if you don't want to turn it on. This isn't an official class session or anything, so there's no attendance. And if you need to leave for any reason, you're welcome to. It'll be recorded, or it's recording already. So,
Well,
um,
I appreciate that. It's more personable usually, and I tend to get more out of it when it's face to face. So,
oh yeah, no
um,
worries. I
yeah.
I will certainly be on video the whole time.
Okay, so I'm just gonna mute mine and the video, and then as soon as I get home, I'm gonna turn all that stuff on. But
No
I'm
worries.
here and I'm listening. So thank you for being here, by the way.
No worries. I like doing these. I think Kareem was gonna come. I'm gonna give a few more minutes for people to get on. Another person. Hi, Logan. I posted the link relatively late. So I'm gonna say we're gonna get going no matter who's here at 4:10. But I'm gonna give a few minutes for other people to join. If you guys have questions or anything, just start to think about anything specific that you'd like to cover. And if not, I went through the exam and I made a bunch of, sorry, I'm hunched over like this. I made a bunch of talking points to go over. So if you have anything in particular, think about it for the next few minutes. I'm gonna run to the restroom, and I'll come back and we'll get started at 4:10, either way.
Okay.
Two Candaces now. All right. Can you guys still hear me okay if I stand here? Yeah? Okay. How do I turn
Yep.
my light? There they are. Sorry. New house. So the chalkboard is not mounted on the wall yet. This is just my dining room. Um, but we will suffice. Um, it looks like we have Logan and Candace, and the recording is going, and not a very interesting first few minutes of the recording for the other folks, but who cares? So I wanted to start. There was Ashley had asked a question in class the other day about whether or not the exams were cumulative, because RJ had mentioned that there might be accumulation to the exams. It's not going to matter quite so much for this retest or for the exam three on Monday. It'll matter more when we get to the exams on the medical and the trauma sections. The exams will never, like the module exams, will never be cumulative in that I'll ask you a question directly about another chapter, but the course itself is inherently cumulative to a degree. So when we get later in the course, there will certainly be things about pharmacology and assessment and airway that you need to know to effectively answer questions on a later exam. But I'll never directly ask you a question from the test bank on chapter 9 later. It'll just be that there will be concepts of the chapters that build on each other over time. So for the next little while, like you certainly won't see a question about, is this patient competent to refuse care, where the question is just straight up about competence. But there could be a question when we talk about poisoning and intoxication about when is it appropriate for a patient who is, maybe moderately intoxicated to still refuse care. That might be a question that comes up later, for example. But I won't ask you, the same question that you saw on exam one on exam five. So I wanted to get that out of the way because I didn't I didn't answer Ashley's question as well as I wish I had when she asked it in class. Um, and I'll say this again in the exam three review later tonight. Um, okay. Do we want to start with specific questions or do we want to start with my little slate here and then we can do specific questions at the end? It's up to you guys. I don't really care.
Maybe start with your stuff.
Okay. My stuff is it's a long list, but hold on. It is it is taken directly from your retake exam. So I made this list based off your retake exam. I won't bring up any of the specific questions, but it will hopefully be very closely linked, um, the generic topics that I talk about. And I am, first and foremost, a math teacher. So that's where this guy comes from. So we're going to start with ventilation. And I think that oh shoot, is everything backwards for you guys? Is that word coming up backwards? No? You can read that forwards?
It's
Okay.
good.
It's backwards to my view, or to my view of myself. Um, so I want to talk a little bit about the A and P of ventilation. We've covered it a lot in class, but I feel like it might still be missing a little bit. And along with that, I want to talk about our parts of the rest of the airway again, like how air flows that whole path. So we're going to start with this being our overall airway. So I'm not a perfect artist, but I do my best. Um, this is going to be our mouth, and this is our nose. So, Annie, you gotta mind your own business. Um, so our mouth and nose are our only two ways really that we take air into the respiratory tract. Um, this area back here, this whole area, we refer to generically as the pharynx. And we split that up into, that glare is really making things hard to read. We split that up generically, or we call it the pharynx generically, and we split it up where up here, this area in the back of the nose is our nasopharynx. And then we have our oropharynx, which is right in the back of the mouth cavity. And then we have this area down here. Now you see it referred to a few different ways in your book, but I think most often we call this the hypopharynx. It's just a nice, easy word that can refer to everything below the mouth and the nose that's in that back area of our airway. This comes up a little bit, not necessarily directly related to ventilation, but when we talk in the class about medications that we administer through the nose, like Narcan, remember RJ said that we want to point them backwards and not like up, even though our nose looks like it goes up, it goes more backwards. Medications won't absorb in this top area of the nose. If we push it too directly upward, like the way that our nose is shaped, then they'll go up and they'll hit areas that don't have a lot of mucous membrane to absorb the medication. So our goal is to shoot it backwards into the red pink area where we have a lot of mucus and very thin membranes on the tissues in there. So the medication can pass through those membranes and get into the bloodstream. And we've learned over the last few years that we can actually administer tons of medications that way. It's in our protocol now to give sedatives through the nose, to give pain meds through the nose. Logan, I don't know if you remember this, but when I was like 9, and you're just a few years younger than me, so when I was like 9, you would have been like 6. They started to offer flu vaccines up through the nose. When you used to, like you always had to get the shot, and they started offering it through the nose. So hopefully less kids were afraid of getting the flu vaccine because they didn't want to, have to have the moms bear hugging their kids to hold them in place so they could get the little shot in their arm. So we could administer a lot more than the nose than we used to realize that we were able to. So that's really everything in our upper airway. This median point between the two, where I've just kind of written a line here, is our vocal cords. and our glottis and our epiglottis. So if we were to take a top-down view of that, it looks like a circle, and then there's two chords like this that open and close and can vibrate, and that's how we talk. You know, the vibration of these chords is what makes pitch. These can also, in bad cases, force themselves together. We call that a laryngospasm. When these two things force themselves together, air can no longer get down in and out of the lungs. And one of the main places we see that is in drowning. As soon as a little bit of air, or as soon as a little bit of water, a little water droplet comes in and gets near them, they immediately want to close up. Their biggest goal is they want to try and stop that water from going into the airway. So usually when we see people drown, a lot of times the actual hypoxia isn't from water getting down here into the lungs. It's because a little bit of water got close. This whole thing sealed itself off, and then air couldn't pass back and forth. We don't really get that like cartoon view where our lungs just get completely full of water and this whole area becomes unable to exchange oxygen. More what happens is this, where our vocal cords close up and they don't allow air to pass through anymore. Candace, you can just chime in. You don't have to raise hand.
Thank you. I'm just wondering what the spelling of that something spasm. It doesn't
Laryngeal.
have
So another name for this is our larynx. This
right.
is our larynx. So when that closes up like that, we call it a laryngospasm.
Awesome. Thank you.
We use this word, and this will come up in a little bit when we talk about different airway pathologies. We use this word spasm for any time a muscle contracts uncontrollably, or contracts very aggressively, very quickly in a way that we don't want. So, like, just like we say, like, oh man, I have a muscle spasm, or people will get like spasms in their back that'll hurt really bad. Yeah, Logan knows about that one apparently. Probably from spending too much time riding a horse. Um, we call this a laryngospasm. And I'll make sure to mention that again later because when we have wheezing, what happens is we have a bronchospasm where the bronchioles tighten themselves up really fast and they start to restrict airflow through. All right, let's open our airway back up again. So these parts right here are our vocal cords. And this is important. I'm telling you, this is important. We have a little flap of skin that lives. Get rid of some of that. We have a little flap of skin right here that's sort of shaped like a leaf. You might want to remember that it's leaf shaped. And that is our epiglottis. So part of our epiglottis's job is when we take in food or water through the mouth, this, the other thing that we bring into our mouth, the epiglottis, which, there's our trachea, here's our epiglottis, that will flop shut to cover the trachea so that when we're swallowing food, it doesn't accidentally go in there. And it's not shaped, it's shaped sort of like this. It's a little bit more like that. And it's just a little flap of muscular skin that can go up and down to cover the trachea so that we don't get anything we don't want in there. And that's our upper airway. Everything up to that point is our upper airway. All the way down to the epiglottis. And our vocal cords, you could really say, are part of the upper or the lower airway because they're the defining thing that means everything above the vocal cords is upper, everything below the vocal cords is lower. So it's hard to say, for sure that will not be a question on your exam if the vocal cords are part of the upper or lower, because it's hard to say that your demarcation point is part of one or the other. Then we have this tube right here. We talked about this pretty consistently in class. That is our trachea. This piece right here, and we have little rings of cartilage that protect the trachea and help maintain its shape. We call those the tracheal rings or the cricoid rings. And they help, just stabilize so it stays a nice round tube. The trachea itself, all its job is to pass air through it. No oxygen exchange happens. It doesn't need to worry about warming or filtering the air because that already happened up here in our upper airways. Its only job is that it needs to stay a nice, round, large hole for air to flow through smoothly. All right? Now we have this little piece right here that I know we've talked about a few times. This splitting point, which the state loves to make a test question, is the carina. That's where our trachea splits into two pieces, and we have our left main bronchus and our right main bronchus. That's our singular word for bronchi. We almost never have to say bronchus because we have millions of bronchi, so we always refer to them as a group. But this point where our trachea splits into the left main and the right main bronchus is called the carina.
Now, is that a typical, when you say question, is that usually how it's phrased in and around?
Usually it is pretty literally phrased as the point at which the trachea splits to go to two separate lungs or something like that is called blank. And the options are like carina, bronchus, lobe, and then, like there's a couple things that are way out there.
Right.
But it's one of those questions where if you know it, you know it. It's vocab. And if you don't know it, you probably are not going to somehow use your intuition to figure out that it's called the carina. Because it's just, a Latin word that probably means split or something.
Fair. Thank you.
Okay. So we have our left main and our right main bronchus. And then when we get down into here, this is where we start to have our trees. You remember I told you in class that these trees split millions of times down their path. When those trees are bigger, like these things, these bigger first ones, we call them bronchi. When we get down to the really small ones, when we're very close to the alveoli, we call them bronchioles. Now, I'm sure there's a scientific definition somewhere of what the difference between a bronchi and a bronchiole is. There's probably like a diameter that defines when it becomes a bronchiole. But for our purposes, bronchi are high in the respiratory tract and they're larger. Bronchioles are smaller and lower down in the respiratory tract. So I'm going to come over here and just, remake a part of our picture to illustrate the lowest parts of the respiratory tract. So somewhere up here, we would have a bronchus or our bronchi. And then down here, when we're very close to the alveoli, these would probably be bronchioles.
So, silly question, but let's say something happened to the bronchi and it shrunk. Would it then be defined as a bronchiole because of its size? I know it sounds silly, but
we would usually consider that an issue. Like that would be like pathological. So we wouldn't rename it to a bronchiole. There would probably be a different Latin name for like reduced size bronchi or something like that. Or like when we have a bronchospasm and these tighten up, they could get as small as a bronchiole, but we'd call them a bronchus that is spasming. We wouldn't change the name itself. There are other little physiologic things like bronchi are able to adjust their shape better because they're larger, they have more musculature to their structure, whereas the bronchioles, because they're smaller, can only change within a smaller degree. So I'm sure the size, like the definition is based on diameter, but the physiologic reason that we call them different names is because they, can do different things being different sizes.
Fair. Thank you.
All right, so down here in our lowest parts of the respiratory tract, we have our little bundle of grapes here, and that's our alveoli. That's our lowest down part of the respiratory tract. Let's get rid of the vocal cords and we'll do a bigger, better look at what one bunch of alveoli looks like. So this would be a bronchiole, and these here would be our alveoli. Now, each alveoli is going to have an artery that comes to it and a vein that goes away from it. So here we have an artery coming to the alveoli. That should get enough. That goes off somewhere in that direction. And then after the exchange happens, we have a vein coming away from the alveoli. All right. Now you'll notice that the colors are flipped here from what we normally expect. This is an artery, and this is a vein. And that's because, remember, we want to stop using so much the definition that arteries contain oxygenated and veins contain deoxygenated. And more importantly, arteries go away from the heart, arteries away, and veins go to the heart. So right here in the middle, where they're touching, we have a little capillary, and that's where our exchange can happen. Do red and blue make green? I feel like they do. So our blue deoxygenated artery comes to the alveoli. We have a capillary where the actual exchange can happen. And then on the other side, a vein is going away from the alveoli. All right. I'm not going to talk too much about respiration yet. We're going to go back to do the whole talk about exchange of gases because I want to focus a little bit more and talk about our ventilation process. So I'm going to clear out some of my markings here. Don't worry about that. Now we remember that this whole thing, here's our actual human body. This is the chest. And here's our neck, and that's going up to the head. There's our mouth and nose. He's a weird shaped guy. Here's our body. Our lungs are there. There's this, I don't know if you've heard of it. There's this little guy that lives in the middle there called the heart. But we won't worry too much about him. I'll just draw him in so we know he's there. That's our heart sitting back where it belongs, not in the way. More importantly, down here, when we talk about ventilation, more importantly, we have a very big muscle called the diaphragm. Now, the diaphragm in real life is actually shaped like this when it's at relaxation. It's pulled upward in like a bowed up shape. And we have our ribs and everything covering this, but that's just going to get in the way. So our lungs are chilling right now. We should be at the end of exhalation in this picture. When we inhale, the diaphragm is going to pull downward and it's going to change to be this shape. It's going to bow itself in the other direction. I'm moving the whole chalkboard. When it bows downward, basically now we have all this extra space that wasn't there before. Now, in addition, obviously our ribs are expanding, so we're making extra space in all directions, not just here on the bottom, but our diaphragm is putting in the most work out of anything else. Now that we have this extra space, we have created a low pressure environment in the chest. We want to equal out the pressure to what it was before. So in order to do that, our lungs are going to open up to fill more of this space. So now our lungs literally have gotten bigger to fill up more of this space when our diaphragm pulls downward. Now, we haven't fixed really the low pressure environment. We've just taken the low pressure that was here. Now it's low inside the lungs. We just transferred where that area of low pressure was. We still want to fix that. Science, physics still says that differences in pressure are bad. In order to do that, we pull in air through the mouth and nose down into the lungs to increase that pressure. So now everything has stabilized out again. We took what was an area of low pressure within the chest, we moved it into the lungs by expanding the lungs, and then we pulled in air to fill up all this space with molecules of oxygen and nitrogen and carbon dioxide and all that. And that is how we get those gases down into our alveoli to make the actual exchange. I know we've covered that several times, but it's just, it's a very physics process and not a very biology process. So especially when we get people in the course that are very, physics backgroundy or very biology backgroundy, this can be a harder thing for them to understand because it relies very much on physics knowledge to get the flow and the differences in pressure and how they interact with each other, as opposed to the biology side of this, which is very simple. One muscle pulls, and that's all that you really need to worry about on the biology side. I'm wondering what this recording is going to look like because I want to make sure that the recording shows my thing as big, and I actually don't know how to do that. Nope, I don't want to do that. I don't think that one either.
You should be able to pin yourself and put yourself in full screen. I don't know if yours is the same as mine.
Oh, I can pin myself. I knew that I could pin. I just didn't know that I could pin myself. Thank you, Candace. I've always pinned other people. Okay. The opposite process, or like the reverse process here, is, everything that we just said, but in reverse. The diaphragm moves upward. It goes back to this shape. The lungs now don't have enough space. We create a high pressure environment in here, in the space where there's not lungs. We transfer that high pressure environment to the lungs themselves by smushing them down, by making them physically smaller again, back to this size that we were before. Now we have way too much stuff inside our small lungs. And in exactly what we know to happen happens, and everything flows in the other direction, and now we exhale air outward. What happens in between that time, we're going to talk about in a second, we talk about respiration, but focusing just on our ventilatory process, this is how our ventilation works. The diaphragm pulls down, creating all this blue space, creates a low pressure environment, which we transfer to the lungs by expanding them. Now the lungs are way too empty. They're the low pressure environment. So we pull air in. We have all that air in there. The diaphragm relaxes. This muscle goes back to the upward bow, this upward position. The lungs are too big. We crush them down, creating a high pressure environment inside the lungs, and all that air wants to blow out of our mouth. Now, on the pathology side of things, like we mentioned a few times in class, that process, letting go, is passive. The diaphragm relaxes. It's going to go back to its upright position, but it's not going to push the air out. The air needs to flow out on its own. That's why sometimes we have patients that have something like COPD and the bronchi go from this to this. Air doesn't want to just flow out anymore. It gets jammed up trying to push all these air molecules through a too small tube. And that's when we get wheezing and we get what respiratory therapists like to call air trapping. If this bronchiole here gets too small, if we narrow that passage way down, air wants to stay here in the alveoli. The pressure is too hard to push any of the air up and out, and it all gets stuck down in the alveoli. What that means is now these alveoli aren't participating in an exchange. They're just holding on to the same air, breath after breath after breath. And we start to get that VQ mismatch thing that we talked about in class. Do we have any questions on what I've covered so far?
What happens with a pneumothorax, like with the
Fantastic question, Logan. That's a great question because it's right in this same part. So we have, I didn't draw it in here, but we have a little membrane that separates these lungs into two different compartments. So imagine there being a little thin piece of skin that separates these. And I'm just going to get rid of some of our extra stuff here. So we actually talked about it. I don't know if we ever mentioned it in class, but we have two different kinds of pneumothorax. We have an open, and I'm going to use this abbreviation that we use a lot for pneumothorax, PTX, and we can have a closed PTX, a closed pneumothorax. So I want to start with open because it's a little bit conceptually easier to understand, in my opinion. Really, the process ends up being the same. So an open pneumothorax is if I like stabbed you and I created a hole in your chest right here. So we have this nice barrier that helps maintain pressure differences, and I make a hole in it. Now, when our diaphragm goes downward, remember what we said, our diaphragm going downward creates this empty space that wasn't there before and a low pressure environment. And we want to transfer that low pressure environment to the lung to make it expand. But instead, now I have a hole here. So instead of pulling air in through the mouth and nose and filling up the lung, we end up just pulling air in from outside and our lung doesn't get any bigger. This lung, because we have that protective barrier, will still get bigger. This one will still fill up. But this one just pulls air in and the lung doesn't get any bigger. As we progress over time, a lot of times what actually happens here is we have a hole, but there's like a little bit of skin still covering it. Like it's actually a very small hole. So air gets in and Our diaphragm then relaxes when we exhale. This lung is going to go back to its normal size. This lung is still doing what it's supposed to do because there's no hole on this side. So that lung's still good. This lung now, all this extra air got in when we tried to inhale. It came in, but what it isn't doing is going back out. So this lung gets smaller, and this lung actually also gets smaller, even though it never got bigger. So what we end up doing is we end up with a lung that's too small. Then we take another breath in, diaphragm goes back to the lower position. We pull more air in from outside on this side. This side, I'm not going to draw it again, but it keeps doing its normal thing. You know, it's still chilling over here. Open, close, open, close, open, close. We pull more air in. This space gets more overfilled with air molecules. And then when our diaphragm tries to go back, the lung once again gets crushed. And it just gets pushed smaller and smaller and smaller as we take more breaths. That's our open pneumothorax. These hopefully are relatively easy to find on an assessment because our mechanism of injury should tell us that there was trauma to the chest of some kind, and we should look for a hole like this. One of our characteristic things for this hole is we call them a sucking chest wound, because when we inhale and all of this air comes flowing in, there will probably be a little bit of blood around that hole, and it makes a like sound as it tries to pull air inward. So the wound literally sucks the air in, and we call them sucking chest wounds because of that. That's our open pneumothorax.
So, is it possible to have that same impact without any evidence, like clear evidence?
That is our closed pneumothorax. That's what we're going to talk about right now. And like I said, I don't know if we ever mentioned this difference in class, which might have been an oversight on our part, but the closed pneumothorax has the same, it has the same end result, but the hole is in a different place. So let's go back to two normal sized lungs. And now when we have a closed pneumothorax, we poke a hole directly in the lung itself. So now we try and go through our normal breathing process. We have our hole right here. This is our hole. Our diaphragm goes downward. We create our empty space. This side still works properly. This side gets big to fill in the space. This side, when air comes in, instead of expanding the lung, the air comes in and it goes out this hole. And we end up having the same issue. So all the air comes out and it fills in all this extra space. And then when we try and exhale, this lung gets small again, back to its normal size. And on this side, the same process happens as with our open pneumothorax. We just can't see the hole because it's directly in the lung. This side, we have all this extra air. The extra space goes away and the lung gets crushed. Part of this, you have to imagine what these flaps of skin look like, because the issue here is that this hole is really good at letting air go out of it, but it's not as good at letting air go into it. So here, as we breathe in, it's really easy for air to all flow out of this hole and fill up the chest so the lung doesn't expand. But then when we go to breathe out, this air doesn't all go back in the hole. If that were the case, then we'd be fine. We'd just have one lung that's not participating in respiration. So I shouldn't say we'd be fine. But we wouldn't have what ends up being a bigger problem, which is a buildup of pressure over here. Because remember, the things that we see eventually when we get to what we call a tension pneumothorax is this lung gets really small, but there's so much pressure in here that it starts to push on everything else. So we see, one of the things we see is we call it a midline shift. So we see that this little piece of tissue that separates the two sides, it starts to bow over in that direction. We also will see our trachea and carina and our heart start to get pushed in that direction as well. So these connections start to look more like this, and that's where we get that tracheal deviation. All of this pressure is pushing everything in that direction. That can start to be what becomes like the real problem, because we actually know that we can have people live without lungs that are exchanging gases. We'll resect portions of lungs on people that have cancer, people that have, just poorly developed lungs. We might have to resect portions. So we know that even if we X'd out this whole lung and it just didn't participate, it wouldn't be good. But if they were otherwise healthy, they could survive. What they can't survive is we have this really big blood vessel right here called the aorta, which is kind of super important. Let me see if I can draw it a little bit better. This aorta starts to get crushed by all this pressure building up on this side, and we start to see systemic effects of shock, things that are going to be on your next exam. We start to see systemic effects of shock because all this pressure is crushing the aorta, and it's not able to move blood with as much strength. So that whole aorta starts to get squished down. And the same thing happens. We also have right here our inferior vena cava, the big vein that returns blood to our heart, and it also starts to get squished. And when these two blood vessels, our two biggest, most important blood vessels, get squished, not enough blood gets around, and we start to have those symptoms of shock.
Okay, thank you. This is really helpful, and thank you, Logan, for asking this question as well. So whether it's closed or open, it can turn into a tension, right? And both the closed and the open are essentially the same issue with the same treatment, just sort of happens differently. One's internally and one's more external per se.
The only difference in treatment is when we have an open pneumothorax, what we'll do, and we learned this treatment during trauma. We haven't learned this yet, so it's not a big deal. But when we have an open pneumo, what we can do is we can take our hand and place it over it. And we use a device for this as well called an occlusive dressing. But in the short term, we take a gloved hand, we place it over the hole. Now, extra air can't get in. Like, it can't get around my hand to get into the hole. And then this is, like a treatment that we'll learn. So I'm not going to get too much into it. But the other thing we can do is when the diaphragm comes upward and it builds this high pressure environment, we can move our hand as they exhale and let some of this air flow back outward. And we call that burping the wound. And then before they inhale, we can cover it up again so that extra air can't come in. And the lung now, because there's no hole in the lung itself, can re-inflate because we're not letting extra air get in.
Right.
So we can burp it, cover it, and then we'll put an occlusive dressing on it to stop any extra air from coming in. We'll learn that treatment when we get to trauma, but that's really the only difference between the two. Because otherwise, we're going to apply high flow oxygen without pressure. We're going to apply high flow oxygen with like a non-rebreather. Because if we do CPAP, then we worsen this pressure issue. So we're going to do high flow oxygen with just a non-rebreather. Or if we need to, a BVM. ABCs still always come first. But generally, we're going to do a non-rebreather for these people. We're going to monitor them closely. We have the same contraindicated things. We won't do CPAP, and then the only other treatment is if it's open, we can put our hand on it. If it's closed, there's nothing we can really do. We're kind of stuck because we can't, get a finger in there and plug the hole directly in the lung.
That makes sense. And then also maybe a blanket to try to, I don't know, reduce the chances of shock, right?
These people are eventually, if they go tension, going to exhibit severe signs of shock.
Right.
And we'd want to do all of our normal shock things. Elevate the legs, keep them warm, supplemental oxygen, like I had already said. Excuse me.
Thank you.
Any other questions about ventilation? Did that answer your question about how the pneumos work, Logan?
Yeah, it did. I just was curious on where the placement of it was usually.
Like where the hole is?
Yeah.
So interestingly, in the closed case, they tend to be lower down. In the open case, it's wherever the thing that opened you stabbed you. So the only tension pneumothorax that I have ever seen was a stabbing. It was someone that got stabbed in the chest right here, and it created an open pneumothorax. And occlusive dressing the whole thing, and she turned out okay. But that was the only one that I've ever seen. The thing about closed pneumos is that they happen two ways usually. One is medical. Remember that we said that our tall white male patients have a very high disposition to have just a spontaneous closed pneumothorax. Their lung will just pop. The other situations are anyone who smoked previously in life. These are still like rare cases, but things that make it more likely to happen to you would really be any kind of damage that you have to your lungs. The other way that our closed pneumos happen is traumatically. We have chest trauma, and usually a rib will poke a hole into the lung, even though nothing happened on the exterior. You break a rib, it goes like that, and it pokes into the lung. With our traumatic cases, once again, usually our mechanism of injury and our patient's other complaints can help direct us in that direction. So say you have a patient, you're doing your trauma head to toe, nothing up here, but then you squeeze here and you get some of that you can feel the bones rubbing against each other. What the heck is that called? I'm spacing for a second. But you feel those bones rubbing against each other. Then if you see that they have the low sats, you do your listening and have less sounds on one side. Now okay, I should be suspicious of a pneumothorax, even if it's not tension. We don't want to put them on CPAP and make a tension pneumo. With our open pneumothorax, we can end up in a situation where we have like both things have a hole in them. Say I stab somebody right here, I could make a hole all the way through like that, and then we end up in a bad situation because the air comes in here and the air might go in like that, and it's harder to regulate what's going on. In that case, we still treat the open pneumo the same way. We're going to put our hand over the open pneumo. There's nothing we can do directly about the hole in the lung itself, but we can still treat this problem to start with. And we can still burp it, all those kinds of things.
Is
All
the
right.
word crepitus?
Crepitus,
Is that the
yeah.
word?
Oh my gosh.
I looked it up.
Yeah, total brain fart on that.
Because I forgot to. Thank you.
Okay, any other questions about ventilation? Okay. Okay, on to respiration. So I'm going to put our, last bronchial picture up here again. So that's a bronchiole. And then I'll put up this will be our alveoli that we're going to look at. And I'm just going to leave this, green part open so that we can, see inside the vessel. So, not worrying about the ventilation portions because we already covered that. We know that O2, which I'll make green because our oxygen that we give patients is green, or the tanks are green, the oxygen's colorless. We know that O2 comes down into here. These are our oxygen molecules. And then, I guess I'll do yellow. In the capillary, coming from this direction, we have lots of carbon dioxide and not a lot of green. A lot of yellow on this side, not a lot of green. This membrane here between the alveoli and the capillary famously is 1 cell thick. This membrane between the two, there's only 1 cell there that separates the alveoli from the blood vessel to make it as easy as possible for things to transfer back and forth. So remember, all of this is about pressures. We need a higher pressure of oxygen in here than there is a pressure of air dissolved in of oxygen dissolved in the blood to force them to want to exchange. That's why we get those high altitude cases where there's plenty of oxygen in the air. It's just not, the air itself is at such a low pressure that it doesn't want to exchange between the two. The issue isn't necessarily the percentage of oxygen, it's the pressure of oxygen. All right? So the actual process, normal, healthy way, is there's very little yellow in here. So this yellow wants to move from the capillary into the alveoli. And there's very little green here. So this green moves from the alveoli down into the capillary. And we have oxygenated blood leave that way. So high CO2 comes in, leaves, low CO2 blood pulls in the oxygen, or low oxygen blood pulls in the oxygen, and then leaves going back to the heart. All right. I'm going to talk briefly just because it was a question on the last exam, and I know that it was I think it ended up being the most missed question, and I didn't talk about it a whole lot in class. This is going to get extra chemistry for a second, but it's worth it, I promise. So in our blood, we have CO2. In our veins, usually, we have a lot of CO2 because there's waste products coming back from the cells. The other thing we have in our blood, what most of our blood is made of, is water. When we have CO2 and water together in our blood, what they form is carbonic acid. So what ended up being the most missed question on the last exam is what drives respiration? A lot of people want to say low oxygen levels, and most people knew that that wasn't the right answer because we talked about how low oxygen does not drive our respiration. What a lot of people want to say then is that high levels of CO2 drive respiration. But what really happens and what the correct answer to that test question was is high levels of CO2 form high levels of acid in the blood. High levels of acid in the blood make our spinal fluid acidic. This is what actually ends up driving respiration itself, is our spinal fluid and the fluid in our brain starting to get acidic. That is what tells our brain to send messages to the lungs and say, breathe more. I know it's a chain, it's a whole chain we have to follow, and normally extra CO2 is what eventually ends up prompting us to breathe. But it's important that it isn't the CO2 itself. The CO2 turns into carbonic acid. That acid gets into our spinal fluid, and that's what tells us to breathe. That's why when we have a patient that's in DKA, we have someone whose blood is very acidic, secondary to them having too much sugar, we still see them breathe much faster because the acid from the sugar still makes our spinal fluid acidic and we start to get prompted to breathe more. So it's important to know on a physiologic level that any amount of extra acid in the blood will make us breathe faster. Normally, in a healthy person, that extra acid comes from carbon dioxide. But when we have other issues like sepsis and DKA that also make us acidic, then we can start to breathe faster, even though the CO2 levels in our blood are staying normal.
So on that note, and this is awesome. Thank you so much. I feel like you should be doing like a show on this, like start your own show because it's perfect. But so how long would it take? Is it instant for the carbonic acid to get into the spinal fluid? Does that just happen almost instantaneously?
Basically, because I'm talking about it like there's a door from the blood vessels into the spinal fluid, but
Right.
really our spinal fluid and our blood vessels like rub up against each other all the time. And all of these things happen slowly and systemically throughout our entire body. So our entire body gets a little bit acidic. And because there's lots of places where the spinal fluid and the blood vessels sort of run next to each other, that acidity can transfer between the two. And really, like this whole thing is happening all at once. All the blood is becoming acidic, and all the spinal fluid is becoming a little bit acidic together.
Okay, thank you. And is there any way to neutralize that, if that makes sense?
So there is, and actually, it's within the paramedic scope of practice. We give a medication called sodium bicarb, and you'll see it on any of the ALS ambulances. So this is sodium bicarb. These HCO3 molecules can grab on to the extra acid and
Okay.
break down the body's or lessen the acidity of the body.
Interesting.
So
That's really interesting. Thank you. And could you possibly, I mean, couple that with alkaline water, or is that I don't
So
know.
usually the issue with alkaline water is that it goes from your mouth to your stomach first, and your stomach is so acidic that alkaline water doesn't have the chance to make it systemic.
That makes sense. Yeah. Thank you.
Um, and our research has shown that this sodium bicarb doesn't really affect the body the way that we thought it would. Like you can't just give somebody a ton of bicarb and expect to fix the issues. What you actually end up doing is just overwhelming the kidneys. So we don't just, when we have a patient that's in like diabetic ketoacidosis or that's very septic and we can tell that they're acidic, we don't just push bicarb to try and fix the acidity because our research has shown that it just doesn't work that way. And my chemistry knowledge and my physiology knowledge isn't advanced enough to understand exactly why. Because our very basic level, like college chemistry one says we have an acid, that's a base, let's put them together and get a neutral solution. And it turns out that that doesn't happen exactly like that. Like it's not good for our body. So the only time pre-hospitally that we really give bicarb is usually in cardiac arrest.
Okay.
And functionality there is similar, but a little bit different. And I don't want to get too far off topic, so I'm not going to talk about it. But basically, this doesn't work as a fix the way that we would hope it to. Someone that is in like DKA, we can't just push this and bring the acidity levels down, unfortunately.
Right. That makes sense. Thank you. And also, just one more thing: when you have like carbonated water,
Yep.
if it if it's essentially making your heart race faster, that could actually impact people with anxiety and would explain, as strange as this sounds, why someone with extreme anxiety would not feel good drinking carbonated water, just
Well,
based on this.
with carbonated water, so carbonated water is acidic for the exact same reason that this makes our blood acidic. The
Right.
carbonation with the water forms carbonic acid. But we see
Right.
the same thing as with alkaline water, where the pH of our stomach is so strong that when we drink carbonated water, when we eat or drink anything acidic, alkaline, basically anything like that, our stomach is almost always strong enough to massively overpower it. So like carbonic acid is not nearly as acidic as our stomach itself is. Carbonic acid is honestly a relatively weak acid.
Okay. So the stomach basically gets in the way of anything that might cause problems with what we're eating or drinking, essentially.
As long as we're eating and drinking things that are food,
Right.
like bleach is a very, very strong base, and that does mess with things because bleach isn't obviously bleach isn't something that we should be drinking. But if we're drinking anything that is like made to be eaten or drank, our stomach will massively overpower if it's super acidic or super alkaline because things that we eat or drink just never reach that far in either direction. Like we know soda's acidic, we know coffee's acidic, but it's not as acidic as our stomach. We know that alkaline water has a pH of 9 or 10, but it's nothing compared to how acidic our stomach is. Bleach is crazy, crazy, crazy basic, so it does mess with things, but it's also not food the way that like coffee and soda and alkaline water.
Right. That makes sense. Thank you. Does that mean that these waters are all a gimmick to
Um,
some extent?
So, I mean, I don't want to, harp on
That's
anyone's
fair.
beliefs here, but physiology absolutely says that they are all a gimmick.
Fair.
Um,
Okay. Thank you.
but
That's cool.
everyone's right to make their own decisions. I drink water from Walmart because that's what my roommate buys. So, uh,
Awesome. Thanks, Angus.
anyway,
That was helpful.
this process right here is our external respiration. And its job is just to move oxygen in and carbon dioxide out. Now, I know I harped on this in class. I'm going to harp one more time that external respiration is called external because there is nothing that separates really our alveoli from the outside world. the insides of our lungs are basically outside. They're experiencing the outside air. That's why we need to warm it and humidify it. That's why if there is, bad things in the outside air, they get in the way of our cellular respiration happening the way that it should. Now, we didn't really talk about it in class, and then I felt bad because there ended up being a test question that referred to it. So I'm going to talk briefly about internal respiration. So our internal respiration, the process is the same, but the point is sort of different. So here we have an artery coming in. There's a vein going out, and once again, we have a capillary in between. So now we have the reverse thing. We have a lot of oxygen coming in over here.
Can you repeat what you just said?
Sorry?
Can you repeat what you just said? You were cutting in and out on my end.
I'm sorry. So we have an artery coming in. We have a capillary that has a lot of oxygenated blood on this side, and then we have a vein going away. And these are cells. And they're any cells. Like all cells need oxygen. So these are any cells. So the question ended up being a little bit more about metabolism. So the process for the exchange here is basically the same as the reverse of what happens in the lungs. So let's say there's a lot of carbon dioxide in this cell. What's going to happen is that carbon dioxide is going to move into this capillary, and this oxygen is going to move out of the capillary into the cells. Now, the question on the exam was basically asking, why is that important? So we have two kinds of ways that our cells can make energy. Aerobic metabolism and anaerobic metabolism. So aerobic metabolism, you know what? Let me make this a Venn diagram. You gotta love a good Venn diagram. So here we have aerobic and anaerobic. Now, the things that these have in common is that they both require sugar. I gotta make this a bigger middle section. This is gonna be an ugly Venn diagram, but who cares? They both need sugar. Sugar. They both need sugar to come in. And they both release ATP, which is our body's carrier of energy, ATP, adenosine triphosphate. Now, the thing that they both also need water, but everything needs water, so we're not going to worry too much about that. The thing that aerobic metabolism needs is it also needs oxygen. And aerobic metabolism puts out carbon dioxide. And this is where we want to be. We take sugar, water, and oxygen, and we create ATP and carbon dioxide. This is our aerobic side. On our anaerobic side, we don't need oxygen. We don't need oxygen to make energy in theory. The problem is, on the anaerobic side of output, we make CO2, but we also make lactic acid. And this is where, like your sports coach in eighth grade tells you to put your legs up in the air after a practice to drain all the lactic acid. And I'll tell you, it doesn't exactly work that way, but he's coming from the right direction that when you're putting out a lot of energy, when you're like running really hard at soccer practice, you're probably not taking in enough oxygen to do aerobic metabolism everywhere. And your legs, we say, start to burn because they build up with lactic acid. Your brain is still getting oxygen, like it's working at its normal pace. So it's okay, it's not getting too acidic. But other places where we're really overworking our muscles by, wind sprints or whatever, they start to run out of oxygen, so they produce lactic acid. Now, the other thing about this is, let me get rid of this. Our aerobic side produces a lot of ATP. One molecule, when we do one round per se of aerobic metabolism, we can produce up to about 30 ATP molecules. When we do one round of anaerobic metabolism, for one thing, we get out this lactic acid that's bad for our body because it makes the blood acidic. And we also produce less than a third as much ATP. So it's not very efficient. It takes more glucose to make the energy, to make the same amount of energy, and it produces acid, which starts to damage us over time. If you've ever heard about like athletes that go way too hard, they can get rhabdomyolysis, or rhabdo as it's called sometimes, is actually when your muscles work so hard and they produce so much acid from this anaerobic metabolism process that it starts to damage your kidneys and your muscles start to die. So that's where that term comes from, is too much anaerobic metabolism. All right. I'm not going to spend a lot more time on that. It was just the one question on the test, but I figured that it could use some covering since we didn't really cover it as much as we should before.
Is that the one? I believe I answered one with lactic acid. Is that the one where the answer was lactic acid?
Probably. It was question 50. It was the very last question of the exam.
Right. Okay. Yeah, I think it was. Thank you.
Yep. Logan, you have any questions on this before I erase it? Hello, dog.
No, I don't. I did notice the question toward the end of the test and I wasn't sure about it, but I get what you're saying now.
Yeah, we didn't give quite enough credit to aerobic and anaerobic metabolism in class, to be honest.
So is this something that is important for our treatment, just as, let's say, EMT, in the EMT scope of practice, or even for just the exams?
I would say it's important for exams. In terms of your day to day, you don't necessarily think about this day to day, but it's one of those things that the background knowledge of this helps you understand how things like rhabdomyolysis work. And when people aren't getting enough oxygen and they start their body starts to do anaerobic metabolism, even if they're not working hard, say they have a lung issue and they aren't getting enough oxygen and they start to do anaerobic metabolism throughout the body, this is part of what explains why they get so very acidic. So it's not that this itself directly comes up in your treatment plans. It's more that it's a key piece of background knowledge to understand other physiologic processes that do affect your day-to-day very directly.
Makes sense. Thank you.
All right, I want to do a little thing on just lung sounds and what is happening inside the lungs that make those sounds. So we're going to start with what we usually consider our most immediately life-threatening lung sound, which is stridor. So stridor is an upper airway issue. I shouldn't say necessarily upper airway. Stridor is an issue that happens higher up in the airway where, wow, those lungs are really mismatched. I just realized that when I looked at myself. So stridor happens up here in this part of the airway as opposed to down in the lungs where most of our other lung sounds happen. Stridor is a whistling sound, and it comes from this upper part of the airway swelling and making it harder for air to pass through. So really, stridor and our next most common lung sound, wheezing. Wheezing is when we're down here in the bronchial tree and these airways start to tighten up. So wheezing and stridor actually are sort of doing the same thing. They're creating a whistling sound because a big tube is becoming a smaller tube. The difference between how we evaluate them is stridor happens here in the upper airway. So we hear stridor either without a stethoscope at all, because you can just hear like, or we put the stethoscope directly on their trachea and we can hear it that way. A wheeze is also a whistling sound made by airways getting smaller, but because it happens down here in the lungs, we have to listen directly to the lungs to hear that whistling sound. And it sounds a little bit different because stridor is one tube making a whistle, and wheezing usually is hundreds of tubes making very small whistles. And when you put them all together, you can hear it's hard to fake a wheeze. It's easy to fake a stridor. But you can hear that like it's a bunch of little tubes all whistling at the same time, as opposed to one big tube whistling.
So what would be the leading cause that we would see, let's say 911 for stridor versus wheezing?
Stridor, 100% prototypical case of stridor is going to be anaphylaxis.
Okay, thank you.
Yep, allergic reactions and that swelling. The other one we might see it would be like so many other things would be trauma, where if something punches your trachea, it's going to naturally get inflamed and swell up, and then we get that same effect. But definitely number one medical cause, anaphylaxis.
Thank you.
Our wheeze, is any pathology that results in inflammation in the lungs. So we see wheezing in asthma patients and COPD patients. That's probably our most common. But we also see wheezing in pneumonia patients. And the main problem in pneumonia patients is that they have fluid buildup and infection somewhere, but the natural result of infection is inflammation. So if we listen right here with our stethoscope, we might get crackles. But if we listen around it, where there's this like bubble of inflammation, we might hear wheezing right here because the issue is fluid, but it's causing inflammation around it, resulting in wheezing.
Right. So, sorry, just back to the difference between the two for my personal understanding. With respect to like asthma, if someone was having a severe asthmatic attack, would that be defined as stridor, or would you put that under like a wheezing category?
Asthma is usually down in the lungs, so it's wheezing.
Right. Okay. Thank you.
Yep. Any of that inflammation, asthma, COPD, any of that inflammation that happens down in the lungs, in the lower parts of the respiratory tract, the bronchi and the bronchioles, that we're going to hear as a wheeze.
Right.
Is this one tube high up in the airway starting to get smaller.
Right, because asthma can feel that way, like your airway is
Absolutely. Yep.
closing, right? And
And
it can almost
a severe asthma attack can progress from down here to up here, but most of our patients with asthma are not getting to that point.
right. Okay, thank you.
All right. What other ones do I want? Erase this quick. The last one that I really want you guys to know, there's, a million lung sounds. The three that I really want you to know are stridor, wheezing, and crackles. And we also sometimes call crackles rails. These are the same two things, just two different names. So rails are from being down here, low in the path of the airway, and we have fluid in the alveoli. So when we hear rails, what it sounds like is like a popping, crackling sound. That's why we also call them crackles. And what is actually happening is there's air trying to flow through this fluid. So basically what you're hearing is it sounds like little bubbles popping inside the airway because there's air trying to move through that fluid and it makes these little bubbles. And then when it gets to the other side, it sort of pops. It's like I can't do it without a straw. But if I had a straw, you get what would happen. Okay. Stridor, wheezing, and rails are the three lung sounds I really want you guys to know. There's obviously other stuff. There's rhonchi and these other ones, but these three are the most important ones. Like I would say the difference between rails and rhonchi, one provider could listen to someone and say that's rails, and another one could come in and say that's rhonchi, because it's like sort of like a subjective, like, rhonchi is like rails, but they're, like it's also mushy. Like, it's this very weird thing to describe. These three are pretty straightforward. And if you get good at listening to these three, then you can effectively do an assessment on almost all your patients. Okay. Um, I'm not gonna spend a lot of time on it in this review session because honestly, I don't even have the equipment for it. But I'm going to tell you something to study for the retake is go in your textbook and look at the actual skill steps for each of our airway interventions. Another one of the commonly missed questions on version 1 of the exam was how do you insert an NPA? And remember that it's like, for example, an NPA is always bevel facing towards the septum. So if you look at this piece of chalk, it's got like a little bevel on the end of it. You can see that it sort of cuts inward. We should always have this bevel facing in towards the septum of the nose, no matter which side we insert it on. And when you get asked a question about an NPA, it's almost always something along the lines of, which way, like how do you insert it? Which way does the bevel go? So not just NPAs, but review the skill steps for NPAs, OPAs, CPAP. Review each of those things in your textbook where it goes step by step how to insert it. I'd review those before your retake exam.
So you're simply referring to the chapter 11, like where there's step 1, step 2, step 3 for oral airway.
Yeah, for like a handful of different airway adjuncts, I would go through and review those skill steps.
Thank you.
A note on the assessment questions. So this exam covers the basics of assessment and airway management. Most of the questions about assessment refer to what does a normal assessment look like for this particular thing. What is a normal pupil check? What are normal lung sounds? What does it look like? Like, which of the following would be considered effective breathing? We can't ask you a whole lot of questions yet that are like, what does a pupil check look like for someone that has a stroke? Because we haven't covered a stroke yet. So, when you're thinking about different parts of the body that you do assessments on, when you're doing your head to toe assessment, make sure you know not only what things you check during your head to toe, but what does the normal check look like for that thing. So, like if we do a pupil check, we expect to shine a light in the eye and we expect the pupil to get smaller. And the other thing is we expect that when this pupil gets smaller, this one gets smaller with it, even if I'm not shining the light in this eye. Our pupils should always move together. So that's just an example, but make sure you know what those normal checks look like for all the different things. What is normal pulse rate? What does it feel like? What are our normal blood pressures? All of those different things. What should the
So,
abdomen feel like? It's not like rock hard.
in terms of normal, is it only to the extent of, let's say, like round, equal, and reactive for pupils, or is it more in depth than that?
No, it's mostly just round, equal, and reactive. And then, for pupils, we know in general that if you're in a dark room, your pupils shouldn't be pinpoint small. Like that's one of the
Right.
things, when we evaluate for an opioid overdose, we say pinpoint pupils. But it's hard to evaluate that if we're outside on a sunny day because their pupils are going to be pretty constricted anyway.
Right.
So normal and then like normal for that environment, I guess.
That makes sense. And in
And
terms of,
you shouldn't need to get too in depth on any of them, but generally what we expect, like we expect our normal lung sounds to be just we don't expect to hear much going on.
right, that makes sense. Now, in terms of skin, because everyone kind of has their own idea of what's normal, I've always had it in my head that pink and dry is what's normal. Is that
Ink, warm, and dry is what
right?
we say our normal is. And the comment that I make to that is pink, warm, and dry doesn't, cover enough of our realistic people.
Right, of course.
So when we say pink, when we talk about color, I like to check mucous membrane. So look at the inside of their lip, look at if you pull down on that like that on their eyes, that
Yeah,
should be pink. Generally, regardless of race, regardless of amount of time spent out in the sun, that should be a warm pink color.
right. Thank you.
In general, for skin should always feel somewhat warm within reason of like the skin's going to feel cold if they just got out of the cold, but there's not a lot of like racial disparity to skin feeling warm. And then skin being dry, obviously, we're talking about the opposite of this. This should be wet. Your mucous membranes should be sort of wet. But we're just checking, are they diaphoretic? Does it seem like they're sweating? So I don't like saying pink, warm, and dry, but that is the prototypical taught thing. And if you had an exam question on it, I wouldn't be surprised if pink, warm, and dry was one of the options. And unless there's another option that's like warm, dry, and of normal color, pink, warm, and dry is probably the one you'd go with.
Right, that makes sense. Thank you.
I often say warm, dry, and of normal color, but it's hard to know what is of normal color for a given person. Some people are very pale no matter what, and some people have very dark skin, and you need to check those mucous membranes to find out if maybe they're pale in what we would consider pale on like a Caucasian person. So it's definitely a balance to be had.
Now, with this basics of assessment, are we going through essentially all 9 vitals to some extent in terms of what's normal in terms of the assessment for this exam, would you think?
Uh, so I can't tell you like for sure what ones will be test questions. So I'll
Right.
say you should know roughly what's normal for all of them.
Okay.
Um, But like I said, none of the test questions are going to be super, super in-depth about it. Like they're still all, it's still all multiple choice questions, that kind of thing. So if there was a question on like what are normal lung sounds, the answer would probably be something along the lines of like quiet and smooth and unlabored. I don't know how you auscultate how labored their lung sounds are, but something to that degree. It's not going to be very, very, very in depth.
Thank you.
Most of them we know inherently as people. Like, I know what normal breathing sounds like because I spend 99% of my time around people that are breathing normally. Um, so stuff like that. All right. Oh, into more of the assessment things. So make sure you know your sample in OPQRST, obviously. I'm going to take a moment to talk about the E in sample and the T, the O and the T in OPQRST because it matters to me. So I'm going to say that the O and of OPQRST and the E in sample refer to generally the same thing. And neither of them refer to when did this happen. They refer to what was going on. And then the T in OPQRST is the when. So the E and the O in sample don't necessarily refer when we say onset to the onset being a week ago, 2 weeks ago, 5 weeks ago. It was, well, the chest pain started when I was walking up the stairs. And then later, when we get to T, I'll ask, how long ago were you walking up the stairs? Um, and that's like its own whole separate point. So that's just a quick tidbit I want to put in there because very often, not so much with the E in sample, people usually get sample down pretty well, but they'll think of O and T in OPQRST being the same thing, and they're completely different indicators. The O is all about what was going on, when it started, and not necessarily when in the timeline that was. Okay. This is a quick thing, um, but you're going to get asked about it, so I'm going to talk about it. That picture. That's the heart. Right atrium, right ventricle, left atrium, left ventricle. Now we know that the left ventricle does 99% of the pushing for the whole rest of your body. The left ventricle pushes out the most force to push the most blood as far away as it needs to go. Fingers, down to the bottom of your legs, up to your noggin. The left ventricle is putting in most of that work. The point I actually want to make is about blood pressures. So we know that we write our blood pressures as the systolic over the diastolic blood pressure. Now we say that when the heart contracts, so when this stuff all squeezes, that is systole. That's the word for when the heart is squeezed. The heart is in systole. Our systolic blood pressure is, say we have, this blood vessel coming down off the left ventricle. The systolic blood pressure is how hard is getting the blood is pushing on the walls of this vessel during systole. When the heart stops squeezing, when it relaxes, it goes into diastole. And the heart actually spends most of its time in diastole. The heart squeezes, lets go, pauses for a minute, squeezes, lets go, pauses for a minute, not literally a minute, usually less than a second. But even when it's relaxed, there's still a little bit of pressure in this blood. The blood didn't just all lose its pressure, it's just not really getting pushed super hard. So when our blood is in diastole, it's more gently pushing on the walls of the vessel, and that's our diastolic blood pressure. Now, we can put these great things in people called arterial lines, or art lines if you're a cool kid. So here we have an artery. We can take basically an exogenous little probe that goes down and sits in our artery, and it has a little force sensor on it. And then we can graph what the pressure inside our artery looks like over time.
Sorry, how do we get one of these things and how do we do that?
Oh, we don't. The ICU does this because they're way
Just
good.
curious. It would be really cool if we could.
Some critical care paramedics can put these in.
Oh.
A lot of transport paramedics can transport someone with an arterial line, and they'll use it to like evaluate their patient. But the hospital usually puts it in for them. Very rare that we put in arterial lines in the field.
Right. How long would it's not a permanent thing, right? So how long would it stay in there?
They're not really that dangerous from my understanding, so it can stay in as long as it needs to, like however
Okay.
long in the ICU, and they want to very accurately measure your blood pressure. But not forever.
Okay. Is it something that someone would, as an outpatient, have
Not
ever?
as far as I'm aware. I've never heard of that at least.
Fair. Okay. Thank you.
So this graph, if we look at, this is relatively similar to what a real arterial line graph looks like. We can trace a line over the top of all these peaks, and that's our systolic blood pressure. This bottom portion is our diastolic blood pressure. This lower part of the line. I know you can't really see those lines, I guess. Our systolic blood pressure is up top, our diastolic blood pressure is on the bottom. We can take the average over time of those two lines. I'm running out of colors that I like. And if we average these out, say it's somewhere right around there, that's our map that I have harped on so much in class. That's our mean arterial pressure, is the average of all of this. Now, we don't use arterial lines, so we use a formula to estimate MAP, or we have our automatic blood pressure cuff measure the MAP if we have like a cardiac monitor, a LifePak, or a Zolec series. But true MAP, it can be measured on an arterial line. I just wanted to draw this. I find for some people, this picture of the graph is more evocative of what it looks like. So the max pressure during the squeezing of the heart is our systolic blood pressure. And then the pressure that remains when the heart's not squeezing at all, that's our diastolic blood pressure.
It does help. Thank you.
Awesome, Logan. I'm very glad to hear it. All right, I have a couple more quick points, and then we're gonna wrap up this review session. I'm gonna get ready for the next one. All right, the first one is about transport decisions. Now I'm going to use sort of an older tool that we don't see as often anymore, but I think that it is a very good tool um, for determining whether or not we are going to uh, transport a patient quickly. And it's called the CUPS scale. Like this, like a cup. Cup scale. This is a mug, but cup scale. So our cup scale goes like this. Critical, unstable, potentially unstable, and stable. Cups. So the reason I bring this up, during your PSE and sometimes on test questions, you will be asked something along the lines of, should you stay and play, meaning should we stay on scene to do our treatment, or should we load and go, get him in the ambulance and start driving, try and do an ALS link up, that kind of thing. Now, how we make those decisions, I think, very much comes from practice and time. But most often when we get asked on test questions, what do we want to do? Like, how quickly do we want to throw this person in the ambulance and get going? These three on test questions usually are going to be load and go, which doesn't mean you get on scene, pick them up, throw them in the ambulance, and leave. But it usually means something along the lines of keep your assessment brief and to the point on scene. If it's a trauma patient, do your head to toe, treat the life-threatening injuries, and then get on the ambulance and do your other little things on the way to the hospital. And then for our stable patients, we might stay and play a little bit more. We might do, for the patient that gets up on their own, walks to the ambulance, sits down, says, oh, I'm kind of having a hard time breathing. That person, we might get our neb started, do all those things, get our ALS requested if we feel like it's necessary. We might do that on scene with the patient and then get moving. I think this really, as an actual skill for the real world, is something that you need to develop over time. When do you stay? When do you go? Because there's sort of a category above critical here that is dead, like stable, potentially unstable, unstable, critical, already dead. And it's funny because it sort of flips when we get up there, because we work almost all of our cardiac arrests on scene now. And like our major trauma patients, we want to do as much as we can to make sure that we have all the bleeding controlled, we have the injuries splinted as necessary, and we know where we're going. Maybe it's the local trauma center, maybe it's flight to a bigger trauma center, maybe we're working near a big trauma center, we're going to go there. We want to have all those things decided before we leave. So it's not a perfect tool, and I don't use this tool in my day-to-day life, but when it comes to test questions, usually anyone that is potentially unstable and upward, they want you to get the basics of the assessment done and then get moving. Because we can do a nebulizer while the ambulance is driving. We can, I don't know, other treatments that we might do while the ambulance is driving, that kind of thing. I don't want you to think that I'm telling you to necessarily do this in your day-to-day life. I'm more just saying when it comes up on a test question, hi Annie. When it comes up on a test question, this can be a helpful tool to use to think along the lines of.
So would that even be like anything ABC related? Like when it would seem like something that maybe realistically we would just fix that on scene before loading and going. On the test, it's most likely they're telling you to load and go.
So it depends on the fixability of it, I guess, is the bad term I'll use for it. So
Okay.
think about our different ways that we can compromise our ABCs. If we have a compromised airway, like there's a potential block, like Like if it's like you know, like a literally occluded airway, somebody ate a button and now they can't breathe because it's blocking their airway. Obviously, we're going to
Right.
stay and play with that because we have a way to fix that.
Right.
If we have somebody that has, trachea swelling from trauma, we can't just give them epi and expect that to fix it.
Right.
So in that case, our fixability is relatively low, and we're probably going to use a BVM on that patient if they're unconscious or something like that. And
Right.
we can do the BVM while we're moving. So if
Okay.
it's fixable things like putting on a tourniquet, that
Right.
we'll do before we go anywhere. But when we're treating one of our ABCs and it's like actually a very imminent life threat, where really all we're trying to do is like string them along. We're not treating the direct root of the issue, like BVMing someone that has trachea swelling from trauma. We're not
Right.
treating the direct issue. We're just trying
Right.
to get them to somewhere where that can happen. We, per test questions at least, are going to do that on the road.
Okay. Thank you.
Yep. Any last questions? All right, I have a couple more things that I had on my list here that I'm just gonna say to look over. Um, some of them are things, like I said at the beginning, that are relevant to this exam, but they rely on knowledge from exam one. One of those is make sure you know your positions of the body, semi-fowlers, fowlers, prone, supine, those kinds of things. Know what those words actually mean. Like, what does a body look like that's supine? Um, they come up a little bit in the discussion on airway. Hi, Josh. Um, and then
So, with respect to patient positioning, is that literally just patient positioning based on photo, or are we talking about if this were to happen, what patient positioning would you use?
it's more if that were to happen, what patient positioning would you use?
Okay, so like the recovery position or whatever.
Yep, stuff like
Okay.
that. If someone is if someone's throwing up, we want to put them in the recovery position. If someone is having a hard time breathing, they probably are going to want to be fowlers. They're going to want to be propped up, more along those lines.
Okay. Thank you.
Yep. And then I had one other thing. Think about mechanism of injury and what it tells us. So, like the state releases trauma criteria that with certain mechanism of injury, patients are supposed to automatically go to like a certain level trauma center. Excuse me. So like a patient that falls from a high height, even if they have no obvious injuries, the state says they should go to a trauma center where they can get, full body scans to make sure there's not something else going on. But that's we're using that as a tool. Think about what mechanism of injury can tell us and where its, fall points are. So I'll do a quick example. I had a patient when I was in my paramedic capstone who drove his car 85 miles an hour directly into a tree. Um, the mechanism of injury there is very large. That's a lot of energy, and it all came to a stop very quickly. So we have a lot of intrusion into the passenger compartment. The whole crush zone on the front of the car is smushed right up. Um, so we can use that as a predictor. But in reality, that patient was completely fine. He didn't have a single injury at all. Um, but we use the mechanism as a predictor or as a tool. If somebody gets hit by a car on the right hand side, like I'm standing like this and a car comes and just smashes into me, then I know that I want to be looking on this side, maybe for fractures, maybe a hip fracture right here, maybe a femoral fracture. I want to look for things like that over here. Mechanism doesn't, just because that was the mechanism
there's no guarantee that I have injuries over here, but I know that I want to check over here because I'm using my mechanism as a tool, as a predictor.
All right, I don't think I had anything else on my list. Nope, not really. I think the talk on open and closed pneumos covered a few things that I was going to say.